All right, today we're jumping into a drug you are absolutely going to see in the ICU, Dobutamine. We're going to break down how it works, when you'd use it, and how to use it safely so you're totally prepared when you face a critical situation. Kind of like this one.
So picture this. You're in the ICU. Your patient is circling the drain in cardiogenic shock. I mean, their pressure's plummeting, their kidneys are starting to shut down, their heart just can't squeeze hard enough. You hear the alarms going off, and all eyes are on you. What's the move? And look, this isn't just some exam question. This is a real-life, life-or-death moment that demands the right tool.
In this exact moment, one of your absolute best friends, one of the best tools in your toolbox, is Dobutamine. It's the targeted support that a failing heart desperately needs to start pumping effectively again.
Okay, so how do we really get a handle on this powerful drug? Let's start right at the beginning, the fundamentals. What exactly is dobutamine, and what do we use it for? First up, let's just classify it, right? Pharmacologically, it's a catecholamine. That just means it acts like our body's own fight or flight hormones. Think adrenaline. Now, therapeutically, it's called an inotropic agent. That word, inotropy, it's just a fancy way of talking about the force of the heart's contraction. So bottom line, dobutamine makes the heart pump harder. Simple as that. So when do we actually reach for dobutamine? Well, officially, its FDA approval is for short-term use when a heart is decompensated. That's a heart that's acutely failing to meet the body's needs. But in the real world, in practice, it's a go-to for cardiogenic shock and low-output heart failure. It's also a huge player in septic shock when the heart's function starts to get dragged down. And think about this scenario, a patient with a massive pulmonary embolism. Dobutamine can be that life-saving bridge that keeps the heart pumping while you get everything else ready for a more definitive fix. Okay, so we know what it does, but how? How does it actually work its magic? The mechanism of dobutamine is, well, it's surprisingly cool, and it's a really key concept to wrap your head around. Okay, now this is where it gets really interesting. Dobutamine isn't just one single molecule. It's actually a mix of two mirror image molecules. They're called enantiomers. The plus enantiomer, it hits the beta-1 and beta-2 receptors. This is what increases the heart's contractility and causes blood vessels to dilate. But at the exact same time, the minus enantiomer is hitting alpha-1 receptors, and that causes vasoconstriction. It's this pretty amazing balancing act happening at the receptor level. So you've got one part of the drug causing vasodilation and the other part causing vasoconstriction. What wins? What's the net result? Well, that powerful beta-1 stimulation gives you that strong squeeze, that inotropy that you're looking for. And in the blood vessels, the beta-2 vasodilation usually overpowers the weaker alpha-1 vasoconstriction. This means you either get a neutral effect on blood pressure or even a slight drop. And we're going to come back to why that is so important. Now, the way the body handles dobutamine is just perfectly designed for the ICU. It's IV only, which gives you incredible second-by-second control over the dose. But you have to remember, in really sick patients with huge fluid shifts or low protein levels, how it distributes in the body can be a little unpredictable. It gets broken down by the liver and then cleared out by the kidneys. So you have to be super vigilant if your patient has liver or kidney problems, because that drug can hang around a lot longer than you want it to. And this brings us to what might be the most practical section. How do we actually use dobutamine safely and effectively right there at the bedside? All right, there are some definite no-go situations for dobutamine. The absolute most critical one is IHSS. In this condition, making the heart contract harder actually makes the outflow obstruction worse. You'd be making a terrible situation deadly. Another huge no is in a tricyclic antidepressant overdose, because it can make their blood pressure tank even further. You're also going to be extremely cautious in patients with atrial fibrillation, since it can speed up the heart rate dangerously. And, while it seems to be safe in pregnancy, that's always a careful case-by-case decision. Because you're directly stimulating the heart, the main side effects are pretty much exactly what you'd expect. The big ones are cardiovascular, a fast heart rate, sometimes high blood pressure, and it can definitely irritate the heart muscle, leading to arrhythmias like PVCs. Your patients might also complain about palpitations or even chest pain. Outside of the heart, headache is the main thing you'll see, and some people might feel a little short of breath. So what's your checklist? What's your game plan? Number one, and this is non-negotiable, before you even think about starting that infusion, check your patient's fluid status. If they're dehydrated, dobutamine's vasodilatory effects can cause a massive drop in blood pressure, so fill the tank first. Then, once the drip is running, it is all about monitoring. Continuous ECG, blood pressure, heart rate, urine output, these are not optional.
You're watching that cardiac monitor like a hawk for any new funny beats, and you're constantly assessing for real-world signs of good perfusion. Okay, let's boil all of this down. What are the key takeaways you need to absolutely nail for your exams and, way more importantly, to shine when you're on rounds?
When you have to talk to the family of a patient on dobutamine, clarity and reassurance are everything. You don't need complex pharmacology. You can say something really simple and direct like, we're giving a medicine through the IV to help their heart pump stronger. And to make sure we give the exact right amount, we have to watch their heart rhythm and blood pressure very, very closely.
And for our final clinical pearl, here is a classic exam question. Why can a drug that makes the heart pump harder actually cause low blood pressure? The answer goes right back to that dual action we talked about. Its beta-2 effect, that vasodilation, can sometimes overpower its weaker alpha-1 vasoconstriction, especially if a patient is low on volume. If you can nail that concept, you'll have a really deep, really functional understanding of dobutamine.